Hello. We are from Group 7 and we are going to talk about tubal ligation. Tubal ligation, or also known as female sterilization, is one of family planning methods. It is a surgical procedure where the fallopian tubes are severed or pinched off to prevent fertilization. Bilateral tubal ligation, or BTL, is a procedure when both of the fallopian tubes undergo tubal ligation. Two methods of tubal ligation is occlusion method and by entry sites or routes. Occlusion method typically done on the isthmic or isthmus position of the fallopian tube. There were 4 types of occlusion method: partial salpingectomy, clips, fallope rings, and electrocoagulation. Partial salpingectomy, used in most postpartum sterilization, and a most common technique is the modified Pomeroy procedure. Clip clamps the tube and inhibit the blood flow to the fallopian tube, causing small amount of scarring or fibrosis, in turn inhibit fertilization. Most commonly used clips are Filsha clip, made of titanium, and Hulka, or wolf clip, which is stainless steel. The fallope rings are similar to clips, blocking the fallopian tubes mechanically. Small loop of fallopian tube is encircled and the blood supply is blocked. Electrocoagulation, or also known as cauterization, is done in laparoscopy. Electric current is used to burn or coagulate a small portion of fallopian tube. The second method is by entry sites or routes. Laparotomy techniques are Pomeroy, Irving, and Acheta procedure. Laparoscopic tubal ligation technique is done under general anesthesia or regional anesthesia. Small incision made and laparoscope inserted through the opening. There, clips or rings are applied, or the tubal cauterization will be done. Minolaparotomy is a procedure done under general anesthesia. Small incision is made at just above the pubic hairline. Then, fallopian tube is lifted through the incision, and blocked using cauterization method, fallope ring, or clip. Vaginal tubal ligation or colpotomy is a procedure for women who cannot undergo laparoscopy or laparotomy. Small incision is made on the vaginal wall. Then, fallopian tube drawn and ligated using suture material. It can be done under local anesthesia, and there will be no visible scar.
If you are having a laparoscopic tubal ligation, your doctor will begin by making a tiny incision near your belly button and another just above your pubic bone. Your doctor will then inject carbon dioxide, a harmless gas, through a tube inserted into the upper incision. The carbon dioxide inflates your abdominal cavity, allowing your doctor to clearly see and work around your internal organs. Next, your doctor will introduce a lighted instrument called a laparoscope through one of the incisions. The laparoscope projects images of the structures inside your abdomen onto a monitor. Through the other incision, your doctor will pass surgical instruments to grasp your fallopian tubes and close them off using the cutting and tying, blocking, or sealing technique. At the end of the procedure, your doctor will allow the carbon dioxide to escape and close the incisions with dissolving stitches. If you are having a mini laparotomy tubal ligation, your doctor will make a small incision just above your pubic bone. He or she will grasp the fallopian tubes with forceps and close them off using one of several techniques. At the end of the procedure, the incision will be closed with stitches. This method is often used just after childbirth. If you're having a laparotomy, your doctor will make a 2 to 5 inch incision in your lower abdomen. He or she will locate the fallopian tubes and close them off using one of several techniques. At the end of the procedure, the incision will be closed with stitches.
Tubal ligation is very effective as a method of contraceptions. It also gives permanent or lifelong protection for women. There are also no supplies needed and no repeated clinic visits required. Tubal ligation will not interfere with sexual activities and there is no known long-term side effects or health risks. There will be pain for a few days after the procedure and will have the risk of infection or bleeding on the incision site if it does not have a proper care. Other internal organ may also injured during the procedure. Some anesthetic risks such as allergic or overdose of local anesthesia or sedation may occur. Other than that, the reversal surgery is difficult and expensive. Tubal ligation is indicated to women who desire permanent sterilization. Other than that, it is for women who had completed childbearing or had a complete family. It is also indicated to women aged 32 years and above, and for women who had going through 3 cesarean procedure as recommended. Contraindicated to women with concern that her decision for tubal ligation was not fully voluntary. Other than that, the women who do not understand the intended permanence of the procedure and concurrent desired pregnancy. Explain to the client that this procedure is a permanent birth control and most of tubal ligation procedures cannot be reversed. Then, educate the client that the procedure would not interfere with sexual desire, but avoid sexual activities until the doctor informs that it is safe to do so to give way for the tubes to heal properly. For post-procedure, teach the client a proper way to care for the wounds such as avoiding contact with water, and assess the healing process as well as watch out for signs and symptoms of infection such as foul-smelling discharge. Explain to the client that she may bathe after 48 hours but avoid straining or rubbing the incision site to avoid risk of infection. Advise the client to avoid heavy lifting and activities that involve abdominal muscle to prevent the wound to open.